Good afternoon, selamat siang, Ibu Bapak. Saya melihat ada 3 orang di sini ya, Bu atau Bapaknya, Anindya, Bu Elizabeth, dan Satrio Wicaksono. Kita perkenalkan, ini Profesor Warren Rubenstein dari University of Toronto, Department of Family Medicine and Primary Care. Dia akan membawakan mengenai interprofessional collaboration and teamwork in primary care settings. So, please, the word.
Okay. Hello. Thank you for inviting me to be part of this webinar. Is it possible for me to know who is out there listening? Would you like to introduce yourselves if possible? And we will hear introductions. Will I hear from anybody?
Elizabeth.
I'm Elizabeth. I'm a student of the Master of Health Profession Education 2018.
Thank you. Anybody else?
Lihat, oh ya ininya.
Satria.
Laporan
Satria.
2 Mei. Laporan. Sini yang kemarin 3 orang kemarin.
Satria.
Ya, halo.
Okay, thank you. I will go ahead and we'll leave time at the end for questions, and hopefully we can interact at that time. What I'm going to talk about today is just an example from Canada, where I work at the University of Toronto, about how we work in teams, how interprofessional collaboration works for us. As you all know, interprofessional collaboration is an important concept all over the world, and I'm just going to introduce, you probably well know about it, but I'm just going to give you a concrete example of how we make this work. Let me just tell you a little bit more about myself. I'm a medical doctor, trained as a medical doctor at the University of Toronto. I work as a professor of family medicine at the University of Toronto, but much of my work is at a primary care clinic, like many of you work in. It happens to be inside a hospital, but it is still similar to a primary care clinic anywhere else in the world. And in this clinic, we teach medical students and residents. And if you're not familiar with the term residents, which many of you are, but residents are those who are training in family medicine after they have completed medical school. This is a picture of the Faculty of Medicine where I work, with a little bit of snow, just so you can see that we do really have snow in Canada. This is probably less than we normally have, but just a little bit of snow for you. And this is a picture of the big hospital building where I work. It's 19 floors high, but it's a big teaching hospital, very close to the university. The university and the hospitals are very, very, very close to each other, similar to here in Jogja. Just a little bit first about family medicine in Canada. In Canada, for the last 30 or 40 years, there's no general practice as you would know it in Indonesia. 30 or 40 years ago, you could finish medical school, work in the hospital, and then go out and work in general practice. But that is no longer the case. All doctors are trained in family medicine. And I'll explain that in a minute a little bit more. In Canada, about 65% of doctors are family doctors, and 35% of doctors are specialists. All the primary care work is done only by family doctors, because there's no other primary care doctors. It's all family doctors. And then we try as much as possible to work not just doctors alone, but in interprofessional teams. Just to understand a little bit about what the path to being a family doctor in Canada is. You finish high school first, similar to Indonesia and many other countries. But as opposed to many countries where you have direct entry to medical school, you first have to do a university undergraduate degree of some sort. It can be in science, it can be in non-sciences. You can basically do as much as you want to prepare you for your medical work. After 4 years of undergraduate university, you then go to medical school for 4 years. And then upon finishing medical school, you either go into specialty training if you wish, or you go into family medicine training, which is 2 or 3 more years after medical school. After the completion of family medicine residency, you can go out into the community and work as a family doctor and do the primary care work. I want to talk now just a little bit first about how we work as in principles of how we apply the principles of family medicine. If I can leave you only with one message for today, the important message would be that if you're going to have a team of professionals that come from all disciplines and that try to work together, you really have to agree on the principles of how you're going to work together. We have lots of examples in Canada where if you try to bring different cultures together, that is different cultures of medicine, and I don't mean outside medicine, I'm not talking about race or religion, but just cultures of medicine are very different. And if you can agree on the principles by which you're all going to work, then it helps the team to work better and to function. And in Canada, we all work under the principles of family medicine, and the teams naturally agree to these principles. And I'll show you three slides of what are the most important principles to us that are really the basis of how family doctors work and how family medicine principles are applied to interprofessional care. So the first 3 things are that care has to be patient-centered, and by patient-centered we mean there's more to what's going on with the patient than the diagnosis. It's more than this patient has colon cancer, lung cancer, diabetes. It's the patient with colon cancer and all the issues that impact the patient from their disease with diabetes and how they're impacted. More about the patient in a minute and how we deal with more than the diagnosis, with the patient as a whole as opposed to just the diagnosis. Number 2 is the patient is part of a family, and that's family-centered care. By family-centered care, we mean you can't treat the patient without knowing more about their family. If any of you have ever been ill, you know that it has a tremendous impact on your family. If any members of your family has ever been ill, it has a tremendous impact on you. So knowing what's going on with the family and knowing how the illness impacts the family is very important. And of course, the family brings genetics into the situation. What is the genetic background? More about their partners, their children, spouses, extended family. That all comes into the equation to figuring out how we're going to provide care and the total care to the patient. And then last but not least is community. So patient, family, and community. And patients don't live in isolation. They live in a community, and the patient impacts the community, and the community impacts the patient. For example, a typical example of the way a patient might impact the community, you maybe have read or aware that measles is coming back again a lot, especially in North America. So a patient enters the community with measles, and because it's so infectious, all of a sudden there's more measles in the community, and that has become a new problem for us again. As part of a community, people work in certain industries that are in the community. There's air pollution, all the things around the patient that affect the patient. And so when we assess patients, we take very, very strong consideration into their impact on the community, the impact of their illness, and then the impact of the community on the patient, whether it be pollution, industry, and whatever other factors happen to be around. And certainly if you're away from big cities, whether people work in the mines, in the forests, or wherever. So that's the first 3 things: the patient, the family, and the community. The next the next three things that take into consideration in patient assessment in interprofessional care are what we call 3 C's. We cheat a little bit with the last one. First is continuity. And this is a very important principle where the doctor and the team commit to patient to care for many, many years, for decades or more. It's not just one visit, one assessment, and that's the end of the care. The care begins and goes on for years, and depending on the age of the patient and the program, can go on for decades. Personally, in Canada, I've treated patients for 30 years or more. So there's a commitment to take care of the patient over a long period of time with one doctor, one group of professionals. So that's continuity is very important, very, very different than a lot of the way patients are cared for around the world. The next C is comprehensive care. Comprehensive care means that we do everything within our skill limit. We treat the patient comprehensively in a sense that there's no exclusion of diseases or problems or age groups. So we treat patients from birth until death. We treat all medical systems, whether it's the diagnosis of physical illness, chronic illness, mental health problems. So we treat the patient comprehensively and treat all the medical problems and mental health problems as much as we can, and psychosocial problems. So it's the comprehensive treatment of the patient. So it's continuous care, it's comprehensive care, and last but not least, it's preventive care, which is a P, not a C, but it fits in. And health promotion and prevention is an important principle that extends beyond just treating the patient and a diagnosis. We need to consider in the principles of care, either by the family doctor and especially in a team, that we're going to take an approach to do prevention and health promotion to try to prevent diseases in the future. The typical example would be diabetes with lifestyle changes, diet and exercise. And then screening, of course. So screening would be the ones that you're used to: pap smears, mammograms, colon cancer screening, other things that we can do to screen for illness in its earliest stages and prevent illness in its earliest stages through many programs. So this is the second set of principles for caring for the patient. We do continuous care, comprehensive care, and preventive care. Last but not least, this is an approach to the patient individually. And this is the difference between seeing a patient, taking a history and physical that we all know how to do, and but going and extending it to what does the patient think? And we have a very common used acronym. Acronym is a short form that we use in North America called FIFE. And it helps to remind us what are the things we need to ask patients every time we assess them beyond just the history and physical and laboratory or radiological investigation of the problem. The 4 items in FIFE, the first F is for feelings. That's meant to ask the patient, how do you feel about what I've just told you? How do you feel about your symptoms? What do you think about your illness? How will it impact you if I tell you that you have diabetes? To find out what the patient thinks and fears, and you never know till you ask. It's always surprising to hear what patients think and fear. So that's an important part of the assessment. What is the patient thinking? What is their biggest fear? It's usually very different than what the team members think. So unless you really ask the patient what their feelings are, what their biggest fears are, you never really know, and sometimes don't have a successful encounter with the patient. So that's the first F. I stands for impact. Impact is what is the impact of the illness, the diagnosis, or whatever you're treating the patient for on the patient's family, on the community. So the typical impacts to understand for the patient is if a patient has a stroke, they may have impaired walking, or they may impaired movement or arm movement or hand movement. And what is the impact for that patient? How does it affect their work, the ability to go to work, ability to care for children? So the impact of the illness and try to understand it from the patient's point of view. The next F is function, which is close to impact, because the impact is really how does it directly affect those around them, but function is how does it affect the patient's function individually. To take further example of the stroke, the patient is immobile, can't move around. How do they go to the bathroom? How do they bathe? How do they function with what we use the term, you may be used to, ADLs, activities of daily living? How does the patient carry on with their daily living activities? And so you may not know until you ask. We don't always necessarily know where they live or how they're living and what is around their home, that now because of their new illness that they can't function the way they did before. So that's asking the patient about how they feel, what they fear, the impact on all around them from their illness, and then the function, how it impacts their function. And last but not least, there's expectations. Expectations is probably one of the toughest ones for all of us to grasp, and certainly for my students, it's very difficult. Expectations is what were the expectations of the patient for that visit, for when you're working with them, for the team, for the members of the team. What were they expecting from their interaction with the doctor, with the team? Sometimes you'd be quite surprised to think that what they expected from you is different than what you thought you could give them. Whether they thought they should have lots of tests done compared to what you thought they didn't really need very many tests. So rather than the patient leaving disappointed, the team members wondering why they can't effectively treat the patient, part of our principles of care is to ask the patient what they expect from the team to help them. So that is what FIFE is all about. It's an approach to the patient that goes beyond all the history and physical examination that we all learned in school. Last but not least is a concept we call finding common ground. Finding common ground means that hopefully the healthcare team and the patient can agree on treatment. And you always want to ask the patient if they understand, if they agree, if they understand what you're trying to tell them about their treatment or their medication. It's always surprising sometimes when we have a clear plan in place, and we don't necessarily ask the patient what they think, but if you ask them what they think, the most important outcome of this is sometimes they really don't understand what you thought was very clear to them. There's lots of medical literature that says patients don't really, when patients leave visits with a healthcare team, they really don't understand exactly what happened, what they're supposed to do. So to ask the patient exactly, do they understand what you've asked them to do, what you've asked, the follow-up, the medication they need to treat, the treatment plan, the other professionals that will come to visit. So to ask so that they can tell you, hey, that's not going to work for me, that's not good, I'm not sure I understand, let me ask some questions. So it provides an opening for the patients to ask questions. So those are the principles of care, principles of family medicine that we apply within our team to the care. And since all of us on the team agree to these principles, we all can work together and approach patients in a similar way. Let me give you an example now of an interprofessional team, interprofessional collaboration, just to see how we really apply how these principles work. And it's a specific example. There's lots of examples that I could give, but this is a very active and new program at our hospital and university. Its short form is HIPS. We love using short forms in North America. I think that's pretty much all over the world now. This stands for Home-Based Interdisciplinary Primary Care for Seniors. It's a program for patients and their families over 65 who may have multiple illnesses, who really have problems coming to the doctor's office to be seen, or going out of their home for services. And we want to provide them all the primary care services as much as possible in their home or very close to their home. It's just makes a big difference that we can get services to them. So in the HIPS program, there's lofty goals. You know, lofty, if I don't know what that word means, that we want to try to accomplish a lot, but little by little. But these are the overall goals of the program. The goals of the program are, first of all, to increase access to services. Many older patients who can't get to healthcare services don't use healthcare services and are missing a lot, and their quality of life is affected tremendously by not being able to access services. So to improve access to care. A major problem in North America and probably spreading all over the world is more drugs than they need, especially as they get older. And that's our number 2 objective, and that's an easier one to measure. You measure the number of drugs they're taking. Careful follow-up of their medications, their fluid intake. They end up back in hospital, and can we do things at home to prevent them from ending up in hospital many times? Other long-term goal is to as many of these patients are older and will have serious illnesses that will cause the end of their life, is to arrange for end-of-life care at home as opposed to in outside the home. Many people want to die at home, and we try to work at such a plan where they can be taken care of at home. And the most important thing of all is that none of this can be accomplished by a doctor working alone. We need to involve multiple professionals in this, and we're working together to try to accomplish all these goals. This is the team. So the team made up of a lot of people, and I'll try to give you an example of how each team member, what each team member does. The most important thing is the family doctor is the leader of the team. I'll come to that in a minute. There are nurse practitioners. Nurse practitioners are nurses with a little bit of advanced diagnostic skills. Our family medicine residents, so those who are training to be family doctors, work on this team so they can learn. We have professionals who provide all services at home. I'll come back to that in a minute. We have a pharmacist member of the team who goes to the home to review all medications. I'll come back to that. The rehabilitation hospital works with the elderly, and then several organizations which involve care at home, and I'll talk to them about them in a minute. But you see, there's about 10 members of the team. This is just a picture of some of the team members. These are the leaders of the team. Just not everybody, but some of the members. It just happens to be 1 man and 6 women, but that's not necessarily the total team. So what's the role of the family doctor? The family doctor leads the team. Coordinates the care, coordinates the activities of the team, ensures quality of care. Quality of care is very important, and QI, quality improvement, is very important. Our government demands of us that we measure what we do and continually try to improve what we do, and rather than just keep doing what we do over and over again and not assume that what we're doing is right. The doctor does make home visits as well to do diagnostic assessments according to the principles, and leads the research to understand, are we accomplishing the goals? And I'll come back to that in a few minutes. The nurse practitioner does a lot of the home visits, does the assessments of the patient, and arranges for the coordination among all the team members to ensure that the care that the patient needs is getting to the patient, either at home or close to home. The terminology that we call CCAC, Community Care Access Center, this is an organization body that sends the services to the home. So the representative on the team, if someone needs help at home, and the easiest example is a stroke, if the patient needs help to get to the bathroom, to get into a bathing situation, to go to use a toilet, then they would have an occupational therapist come to the home to set things up for them. If they need strengthening, if they're weak on one side from a stroke, then we would send a physical therapist in to the home to help them, give them exercises to improve their strength. All the rehabilitation kind of things that can be done in a hospital but are done better at home. Another example is home nursing. We have nurses who go into the home who, for example, if a patient has a bad wound from a fall or after surgery, then they can do wound care and go in daily to change dressings and do proper wound care. So that's the general home care services that are provided through this one organization in our system. The pharmacist on the team plays a very important role. The pharmacist goes to see every patient and does an assessment of all their medications, tries to understand the indication for every medication, and then goes over those medications with the team. And as you remember from the previous list in our goals, to reduce polypharmacy was our number two goal. And the pharmacist is the main one who's going to help us with that. And then the person from the rehabilitation hospital who plays an important role in the team is training programs training patients to prevent falls. Falls all over the world is a big cause of morbidity and mortality. In Canada, we have a second problem. You don't have ice and snow. We have ice and snow, which makes falls more of a problem. So we have special programs set up to teach patients how to prevent falls, if they need assistive devices like canes or walkers, to do everything we can to prevent falls, to prevent the morbidity and mortality. We have a program called Meals on Wheels. Elderly people who may be living especially in big cities where we are, where their family is not there, they live by themselves, their partner has died. Sometimes they have trouble getting access to food. They can't get out to buy food, or they can't cook food. They may not have a Gojek to bring their food in. So we can arrange for food to be brought into the home for them once a day. They get once a day delivery of one major meal a day. There are neighborhood community programs, if at all possible. If part of our assessment is that the patient is isolated and not getting out, we try to get the patient out to community programs that will be near their home. And then if they're very isolated and really can't get out at all, the organization called Circle of Care will arrange for volunteers to go visit the patients and spend time with them, so they aren't as alone, and they will have someone to talk to. And very importantly, we have geriatric specialists who are involved with our team. And the geriatric specialists, when we have complicated problems where we need advanced patient assessment, we can call on the geriatric specialists who are part of the team. They're available for consultation at all times. If someone is visiting the home of the patient and there's a complex problem they can't figure out, they can call on the telephone, they can use WhatsApp. So the geriatric specialists are always available to us. They sometimes do home visits, the geriatric specialists do, or the patient may come into the clinic if necessary. The geriatric specialists attend the team meetings, which I'll come to in a minute, and they're also available through telemedicine. So the same way that I'm speaking to you on the webinar today, we have portable telemedicine where the patient can be assessed through the internet at their home using telemedicine. So the specialist does not have to necessarily come and see the patient in their home. They can do that with a webcam and a computer that the team brings into the patient's home. And last but not least, the family medicine residents are part of the team. Each resident follows the patient for 2 years, so throughout their training, so they get to know the patient and get to learn all about the patient. They make regular visits to the patient's home. They interact with all the professionals on the team, so they learn how to work with all the different health professionals across the spectrum of healthcare, and they're supervised and get feedback on their work from the family doctor who was leading the team. So those are all the members of the team and their roles, and you can see it encompasses almost everything that you might need for taking care of a patient in the broadest manner possible. A little bit about how we assess each patient, and I won't go into too much detail because this is another whole presentation. This is more about how we work together. But each patient, when they on entry to the program, they are assessed and they have a coordinated care plan. So for each of the professionals that may be able to help, there is a plan of how that professional is going to work with that patient to help them with their health care. Copy of that care plan is kept in the patient's home, so everybody knows what's needed for that patient and what professionals are going in to help. And there's a copy in the patient file, of course. All the professionals they visit as needed, according to the care plan. Sometimes there are several team members. Sometimes there's only one team member. It depends on the care that patient needs and which professional they need for their particular health problem. The interesting side, people have asked me, how is this program paid for? There's no extra money for this program, except sometimes the patients may have to pay a little bit for their food, because that's not covered by universal health insurance. So we have universal health insurance in Canada, like you have here in Indonesia. So it's all covered by our universal health insurance program. The doctors are paid by capitation, which I've heard you have capitation here in Indonesia, so that there's a fixed amount per patient that is assessed and taken care of, and all the rest of the professionals are paid for through global budgets provided by the government to their organization or works at the team. So we didn't ask the government for more services. We didn't ask the government for new money. We just took the services that patients weren't accessing. Everybody was working by themselves, and we use the expression in silos, separately, individually, rather than providing a coordinated care to the patient. And patients weren't getting the services that were available to them. And by bringing all the professionals and organizations into one team to assess the patient, we hope we'll be able to increase care, and we'll talk about that shortly. So no extra cost to government, just using services that are currently available and that weren't really being accessed the way they could be accessed. And just a brief comment to keep the team organized and together. There's a standardized patient assessment based on the principles of family medicine that I described at the beginning. Everybody uses the same form. The family doctor will review it all because he or she is the leader of the team and is responsible for care for the patient. Again, I'm not going to go into detail of the assessment. That's another topic, and you're all familiar with that. But we look at all to meet the goals and to get all the health professionals involved. We have to know what's going on in detail with the patient. So we assess the medical problems, patient's medications, ADLs, which stands for activities of daily living, the social supports, their family, meaning is anybody around? Does anybody live in the same city? Are they alone? Do they have anybody else who can come and visit? Is there anybody in the community who they're connected with? ACP stands for Advanced Care Planning. So if they're near the end of life, or even long before the end of life, we talk to them about how would they like to die? Do they want to be resuscitated? Should they be found near death at home? And that's an important discussion. MOCA is the Montreal Cognitive Assessment. So we do a cognitive assessment on every patient to see what their mental capacity is. FALS assessment, of course, for the FALS program, vision and mobility assessment, all the important things to keep the patient to try to improve the patient's function overall. And then at the end, as you can see, it could take hours to create a care plan for each of the issues. Some patients it's simple, and some patients it's very complex. How does the team work? The team meets every 2 weeks. they all get together at the clinic, so at our clinic, because the program works out of our clinic. So they come to the ambulatory clinic, to the primary care clinic, to meet together. They review all the patients who are being taken care of. They review the care plan for every patient. And people always ask, what do you do in between? Because patients have complex problems, and how do you keep in touch and deal with emergencies and acute problems? And with WhatsApp, it's very simple. WhatsApp is the key device that allows all the professionals to communicate, and that allows for effective care for issues that can't wait until the bi-weekly meeting. As I said before, we really have to show that this program can make a difference. Can we actually meet the goals that I outlined in the right at the beginning of this presentation? This program has now been running for 2 years, so we don't really have enough data yet. Remember, our number one goal was to increase access to health services that already exist. And 2 years, the before and after is there's a 38% increase in access to services overall, meaning from the time the patient entered the program to the 2-year point, there are 38% more access to services compared to when they first entered the program. And that includes all the services that we offer to them. To see the other goals, to reduce hospitalization and emergency department visits, all the other goals that we have listed, will take a longer period of time to see if we're really making a difference. And we certainly think we are, but we hope to be able to measure it and tell you more about that. Why this program? There are important reasons for it. It's very important to our Ministry of Health. I was talking to some of your Ministry of Health people yesterday. It's very important to our Ministry of Health. They saw the same problem of services not being available but not being delivered. So they were looking for ways to make sure that healthcare services were delivered effectively to the population. And they were actively encouraging this type of team care. Also from the public was long complained about not being able to get the services to them that were available, and there was a bit of a confusion in healthcare delivery, and healthcare delivery needed better coordination. So interprofessional team care is hopefully one of the answers to that. We want to do everything we can to keep people at home, which is in the objectives. And most of these programs, these kind of programs, work to keep people at home. And for governments, it's hopefully saves a lot of money. You can save a lot of money with these kind of programs. There's lots of research around the world that shows that interprofessional team care results in improved patient outcomes. I won't get into that literature now, but that is widely established, and that's why it's become such a common theme all over the world to try to provide interprofessional care in teams to improve patient outcomes. And I think there's been lots of evidence that it does work. And last but not least, from an education point of view, we want our family medicine residents, our doctors in training, and students from other healthcare professionals, the nursing students and whoever, who all come to work with us. We want them to work together so that when they graduate, they can understand that this is the model of care that can be used, that they get used to this model. And we have, from all our models of care, we get lots of feedback from our learners that I understand that this is how we work. This is the best way to work. Our learners actually tell us that can I work like this when I graduate? And the answer is yes. We want to try to make sure that when you graduate, you can work like this. That it's not just something for teaching hospitals and for medical schools. So the learners get used to working in an environment which is interprofessional, and they accept that as the normal for them. So they want to work like that when they graduate. So there's lots of other programs that we could talk about. If there's questions, I could mention. We family doctors. We work with in public education. We do public education for the greater community. We work with the schools together. We work with public health, with the public health department a lot, with immunization, for example, and a big program some of you may have heard of. 10 years ago, 12 years ago, we had a SARS outbreak in Toronto. SARS is severe acute respiratory syndrome, where the family doctors organized the care for patients for this serious viral illness that was new to the city and came in for the first time. And we have, and even in our primary care clinic, not even, but especially in our primary clinic, we have other interprofessional care programs. But the purpose of today's talk was to tell you more about the principles of family medicine and how they become an example for this primary care program for elderly seniors, and one example of how you can apply the principles of family medicine to interprofessional team care. So I'm gonna stop now just to summarize that interprofessional care is important for the future of healthcare delivery, that the principles of family medicine and family doctors as leaders of a interprofessional team can be very effective for the delivery of healthcare. And these principles and these teams are very important to all over the world now, to patients, government, and educators, and hopefully will, in all countries around the world, will become an effective way to deliver care. So I will stop there. I think I've fit within my time. And if there's any questions, we'll try to hear them on this end. So I'll leave it to my technical experts here to try and help out with questions. So please, any questions that you might have, or explanations of some of the things. I presented a lot of information. So I'll stop now and wait to hear if there's anything.